I'm going to get a little bit more into the weeds here now, away from the government policy and into the work going on. I'd like to introduce Nancy Foster. Nancy is the Vice President for Quality and Patients. Actually, I'm going to Orla first. We'll come back. Got thrown off here, so my apologies for that. Mrs. Staunton is one of the co-founders of End Sepsis. You've heard from Kieran earlier on, and Orla is now going to give us a little bit of the story of her family's experience is probably not the best word, but experience with sepsis. Orla.
Thanks, Dr. Doffler. I'm just going to start by showing you a photograph of us as a family. A bit battered, but not sure you can see it, but it's Kieran, Kathleen, Rory, and me. And I'm Rory's mom. I have two children, Rory, who is forever 12, and Kathleen, who is turning 23 years old. And she was 10 when Rory died. Sometimes it's easier to talk about the things that should be done than talk about your own story. But I still find it really awful to say that Rory is dead. And I find life without him incredibly difficult. But like other stories you've heard, Rory was such a welcome baby in our lives. And he was born on May 13th, 1999. He was an adorable child who never became a teenager. He was 12 years old. He was 5'9" tall, 169 pounds. He was a huge fan of Captain Sully Sullenberger. He wanted to be a pilot. He loved to ride his bike, play with his friends, and he was absolutely passionate about politics and debate. So back in 2012, on March 28th, Rory went to school and, he fell in basketball class and he scraped his arm. You know, he wasn't a big sports kid. He liked to watch it, but didn't really like to play it. You know, he was really proud when he came home that evening and he said, "Mom, I went for the ball and I fell and, you know, I scraped my elbow." And I saw 2 band-aids on his arm, and he told me that the gym teacher had put the band-aids on his arm. What we found out afterwards that the gym teacher didn't clean the wound and did not send him to the nurse who was on duty. I didn't know that at the time. So after midnight, I woke to hear him like throwing up in the bathroom. And when I went in, he said, "Mom, it's the pain in my leg, it's the pain in my leg." And so I rubbed his leg and I was like, "What am I doing?" I brought him back to bed and I said, "You know, I'll be here with you, it'll be okay." And I realized he was in a lot of pain and just, you know, he was really uncomfortable. So the following morning, he had a fever of 104. And we called our pediatrician, and her office said she'll see you at 6 p.m. this evening. So at 6 p.m., we were in her office. I had actually held him up as he walked into the office. He, you know, he strongly told her in his own words that the scrape in his elbow, and he showed her where his skin was becoming mottled. I had never known what mottled skin was, what it looked like, nothing. And he talked about the pain in his leg, and he talked about his stomach being tender. And you know, I kept trying to make eye contact with her, and I said to her, you know, "Is there anything we should be worried about here?" And she said, no. The pain in his leg is from his fall in gym class. And he kept saying, it's not. And you know, she looked at the scrape in his elbow, and then she didn't have any comment about it. And she said, "Look, there's a stomach virus going around New York," because he had thrown up in her office. And she said, "This is what it is. It's a stomach virus." And I've seen so many children look like him in the last couple of weeks. So because he hasn't had much fluid today, I think you should bring him over to the ER room and get them to rehydrate him, but he's going to be fine. And don't worry. And so as a family of four, we made our way over to the emergency room, and it was she also had taken all his vital stats, and what we didn't know at the time was they were off the charts, but it never obviously made an impression with her in any way. So we went to the ER, and they agreed with the pediatrician and said no, his stomach is because of his stomach virus, and but they did collect blood, and they gave us a prescription for Zofran, and they said, go home, he'll be okay. Give him a week or two, or a week actually, 7 days, and he'll be good. And they wrote on his chart, patient improved. So we brought him home, and he fell into a very deep sleep. And I remember looking in at him several times and thinking, oh, good, he's sleeping off this fever. He's sleeping through the stomach virus. And I actually felt really great that he was in this deep sleep. And the following morning, we knew he wasn't much better. And so we repeatedly called our pediatrician because he was really complaining about pain and he was very out of it. He used to love to watch CNN and he wouldn't even look at it that day. And we were told to just keep getting fluids into him and to control his temperature. But he didn't get any better. So that night she said to us, bring him to the hospital. So we raced into the hospital with him on that Friday night, and he was admitted to ICU. And even as I stood in the emergency room with him that night, and he kept looking, following me around with his eyes. And I had seen my mom do that with my sister because she's a nurse before she died. And I realized that he was counting on me to make him well. And I remember saying to the doctor, is there anything here? And he said to me, well, have you seen anything on his body? And I said, it's just a scrape. And he said, I'm not worried about the scrape. That's okay. But his symptoms got worse, and they admitted him to ICU. And what we know happened is that an infection had entered his body through the cut in his arm. And so when we brought him to the pediatrician to the hospital, he was already in septic shock. And in fact, in the emergency room at that point, he was fighting for his life. And the blood that had been collected, that had been gathered at the hospital, had never been viewed as important. And when he lay in the emergency room that night, nobody thought to go up to the emergency room and to tell the doctors that this kid was actually dying. So he fought valiantly from Friday through to Sunday, but he didn't make it. I realize now he didn't stand a chance. And despite the wonderful work that the ICU staff did, and how comforting and caring they were to him and to us, he didn't make it. He really didn't make it. So this morning before I came on, when I was thinking about it, I thought, how many times he could have been saved. And, and these were the areas that we focused on in our work after he died. And, I'll start with, I wish I had known what sepsis was. And I feel guilty that I didn't know what sepsis was, but no one had told me. I had never seen anything. No one I knew in the neighborhood I lived in, and it was a big family neighborhood, knew what sepsis was. So that was strike one against him. Strike two is when, we brought him to his pediatrician. And actually, strike two was actually his teacher in the school when he fell, that didn't realize that you need to clean this cut and you need to send him to the nurse and you need to make sure he's okay, because even a small cut can be very serious. And then strike three was definitely, his pediatrician, who should have recognized the symptoms that he had sepsis. And then, of course, strike four is the ER doctors who did not read his bloods, who sent him home to die. So there were many opportunities to save his life. And and nobody did it. And it felt like nobody cared enough to do it. And I know that's not true. And I know I have met the best of doctors, the greatest of doctors, but I still think he was just a little boy. He was 12 years of age. He deserved better. So I guess all I want to say is I have met wonderful patient advocates across the United States and across the world. And I know that we all feel that our loved ones shouldn't have died. And I think we want all our loved ones to inspire everyone to do better. And that's it.
Thank you, Rama. You and I met many years ago now, not too long after Rory's death.
That's right.
And listening to the story never gets easy. I'm sure telling it is even harder. And so I want to thank you for putting yourself through the last 5 minutes. It seems like an hour, putting yourself through these years and the work that you, Kieran, and the entire sepsis community have been doing. And pause again to allow all of us to digest the reality of what a preventable death means. It's, in the intensive care environment, which I inhabited as a clinician, there are a lot of things we encounter that aren't preventable. In the emergency room, there are also things you encounter that aren't preventable. And you have to steel yourself to move forward as you encounter them. The preventable things you carry, and you come back and ask yourself. And again, I just want to thank you and the whole patient advocate community for the attention that you have been bringing to this, will continue to bring. If our government does have the wisdom to fund this year, or when we get around to it, and hopefully really is this year, to a higher level, and all of the folks who are working on this from the last panel and the folks we're going to hear from and those who are unheard from today, I just am really appreciative of all of the efforts, and really just it's not even so much the effort as much as the will to continue to subject yourself and to the pain of this. So thank you. Some of what we're going to talk about now, and I am going to shift to work. One of the things that Foster raised before was, what's going to change the game here? What are we going to do different? CDC did release earlier this year some standards. My opinion is it's a big move in the right direction, and I'm not alone in that. And so in this next panel, we're going to hear from two groups. Nancy Foster, I'll introduce here in a moment, from the American Hospital Association, and then a group from my former employer, Northwell Health, who are continuing to work on sepsis now for many, many years, and they can tell us more about it when it's their turn. But Nancy Foster is the Vice President for Quality and Patient Safety Policy at the American Hospital Association. And Nancy, I look very much forward to how you see the work going on now and how the CDC, AHA partnerships, et cetera, are going to move us forward. So
thank you. I appreciate the opportunity very much. And Orla, please let me thank you as well. We know that when you're trying to create change, there are three important factors that will drive and be a part of every change effort. One is fuel. It is the passion and the stories that bring the passion to making care better. And you have just told a very powerful personal experience that touched each one of our hearts, and it will fuel all of us going forward. There are unfortunately too many such stories, but we'll talk about what will happen, how we're using that to drive care forward and to drive real improvement. The second thing is friction. We will encounter friction in every effort to change because we are all humans. We all like things to sort of be predictable, but figuring out what tools can we bring, how can we create change has been part and parcel of the work of the American Hospital Association with our member hospitals for the entire time I've been at AHA, which is now over 20 years. It took on additional importance in the early 20 teens when we were part of the CMS HEN and HIN work. Those are acronyms that talk about improvement and engagement networks in which we're bringing hospitals together to learn from each other and to help and support each other in driving care forward. And that work continues in a variety of ways on a variety of topics. I'll talk about some of the products from that. And then flexibility is the third F. That flexibility, because America's hospitals are part of the opportunity here to improve care, certainly at the very sharp end of the point when we're talking about people who are septic and who are headed toward septic shock, a critical part of that. But so are the pediatricians and the primary care doctors and others who are touching the patients, who are seeing the patients, and importantly, having the families and the patients themselves understand sepsis and its consequences if it goes untreated is a really important step forward. So let me ask for the next slide. And as they're pulling up the next slide, I will tell all of you, I am here in Washington, D.C. I work on policy issues, which means I have the privilege of working with some of the folks that you just heard from at CMS and at CDC and the FDA and others. But I have a whole team of colleagues that are in our Chicago office that are doing all of that important work to help our members understand the science, advance care, and come back to it. So what we know from the work that we've done now for more than a decade on care improvement was captured in a 2023 release from my colleagues in the Chicago office, talking about strategies and tactics to reduce infections. I bring that up here not only to point to some good work of my colleagues, but also to tell you that there is such an alignment between this and the core elements. So we are on the same page. We are embracing the CDC core elements and encouraging our hospitals to look at them. These are notions that are common to every kind of quality improvement work that we're doing. They are foundational, we believe, and so do others who are working on quality improvement to actually advancing care. And you see the ones highlighted here in red on my screen, on my slide, really are some of the most important things that can be done. Building a culture of safety that really engages board, the leadership, and the entire staff. Preventing infections, preventing the spread of infections is not something that just clinicians have to be involved in, right? The housekeeping staff, the dietary staff, everyone who comes into contact with a patient or family has a role to play, and helping them see that they have a role to play is part and parcel of the work that we do and others do in advancing safety. Engaging patients with real-time data and feedback is so critically important, and that depends on having good measures. We just heard about the existing measures and the plans for the new outcome measures. AHA, as a policy position, has been supportive of the development of an outcome measure for sepsis for several years now, since the notion first began to be discussed. We're really delighted to hear we're nearing the point where we will see that outcome measure. And for reasons I'll talk about in a few minutes, we think it's important that in whatever way makes sense for CMS to do so, that we phase out the existing SEP 1 measure and really focus on the outcome measures, because that's what we're trying to drive. We're trying to drive better outcomes. And by doing that, you create room for innovation that may lead to even faster improvement. So we can talk about that, but the data and feedback on sepsis is now on every hospital leadership board that I have talked to in the past 2 years. So know that it is there and that it's an important part of their work. The improvement teamwork is so vital inside of hospitals, and that relies on communication. We are getting better at communicating throughout the hospital, but it is imperfect. Some tools have come along to be helpful there. Our EMRs, our electronic medical records, are one of the most critical tools we have, particularly when those are coupled with good decision support. It really helps highlight to the very busy practitioner what's going on and how to drive it forward. And then that fourth highlighted item, engaging with patients and families, helping them understand what's going on, recognizing and helping to drive it forward, is so very, very important. And we are getting better at it. We are not perfect. Next slide, please. To help along this way, these are the kinds of tools that AHA has created, both videos and documents and conversations across the board. One of the things we've recently released to help engage the C-suite, the leadership of the board and the leadership of the hospital and the board of the hospital, is this conversation about quality, and it includes many references to conditions such as sepsis and so forth. These are tools that are readily available on our website. I invite anybody to go look at them that might want to do so, but no, this is not the full array of them. We are constantly updating the tools and putting out new information. We are so enamored of the work that CDC does around infection control that anytime we see something new from CDC, we will put it out to our members and encourage them to take a look and see how it will work in their organization. And just to talk about that, and you would see this if you went to our website and looked at some of these tools. Some things work better for a large, multifaceted, multidisciplinary organization like Northwell than they do in a small 75-bed, more rural hospital, or in a 5-bed rural hospital. But all of them have to be prepared to recognize sepsis, and to react to it, to transfer the patient when necessary, and to really ensure that that patient gets the right care. So we're trying to create a tool set that will reach to all of those or different types of organizations. It's also true that we need measures that help all of those kinds of organizations. Sometimes the very small organizations cannot get an effective feel for their performance by looking solely at outcomes measures, because they don't have enough patients that have that outcome to really make it statistically meaningful. So we need other ways of examining this. Sometimes it works that you then examine every case that comes in, or there are other approaches to looking at this. But understand that that's why I was talking about flexibility before, is that all of that flexibility is really geared towards helping the hospitals where they are, caring for the patients they're caring for, figure out how they're going to care for every different kind of patient who comes to them and presents with a critical issue. So I will take the next slide, please, if you will. And as I said, friction is the second tenet of this group of factors that I was talking about. It won't be easy making this kind of change, in part because of all that is going on inside of hospitals. We at AHA just today turned out a report, and I'll share with you the findings of that report in a minute. But in part, the report says that our inpatient population is getting much more complex. That's understandable. Everything that's getting simple to do, or that is relatively simple to do, is now being considered for an outpatient setting, right? So we're pushing some of the simpler things out of the hospital to make room for patients who truly need inpatient hospitalization, and there's no second choice there. So as that patient complexity increases, the patients are more demanding in an era where we see large numbers of vacant slots, nursing, PT, physicians. There's a shortage of qualified professionals, healthcare professionals across the board, laboratory professionals and others that will be vital to the work on sepsis. So that will create this dynamic that will be hard to adjust for. We're innovating in order to create ways to deal with that. Many of the recommendations, including our own, call for critical issues such as sepsis to be on the leadership agenda. Many times people voice that as being on the CEO's agenda. There are so many critical issues today that if you rely on only one person to have that responsibility, that CEO, there won't be much time for it. So, and they're all vital and critical issues. They include things like improving health overall, improving community health. Many of our hospital leaders are spending a lot of time thinking about how their organizations can partner with others to advance community health. Northwell is among them, and I wish I could present some others for you because there's some really innovative and exciting things going on in that realm. But that takes a lot of time and effort, including finding funding for it, because those efforts are not paid for out of care for sick people. So improving health is a great thing to do and includes reducing the infections that people get, whether or not they ever need hospitalization. The second thing I would point out is maternal mortality is another critical issue we're addressing. Equity, because we know that there are inequities in health and in healthcare, and we want to eliminate them. Workforce safety. Our staffs are at greater jeopardy now than they ever have been from being injured during the course of giving patient care. And that's totally unacceptable, but a keen interest to the leaders of the hospital to address. I mentioned workforce shortages. That's a huge issue. And then there are sort of new opportunities, the use of AI and how it might drive care forward in good ways, in ways that are very helpful. But it takes time. It takes attention of the leadership thinking about how do we make sure that this brand new AI application is actually safe for care of our patients. And then there are all the usual things that a hospital leader has to attend to too. So we want flexibility in the language of some of the things so that we can make sure that the person who is given the responsibility for it, whether that's the CEO or the chief medical officer, or the chief clinical officer, or anyone else in the organization, really has the bandwidth to give that leadership that issue deserves, including sepsis. And, we've alluded to this already. Real-time data reports are vital to driving things forward, but they're not always available in every institution. Those of us who have the privilege of going to a large academic medical center for our healthcare are sometimes amazed at how different it is in a small critical access hospital that cares for a community of rural people. And that they don't have the same robust electronic health records that a large system will have. So unless they are part of a large system. So those things come into play. They also don't have the broad number of physicians may not have easy access to some of the same expertise that exists or experience that exists in larger institutions. So figuring out how we can help them tap into the expertise has been an issue for sepsis and some of the other critical and urgent issues that are confronting hospitals these days. And as I mentioned, inequities in health are real. They are troubling, and we are working on those. They require a lot of interest and expertise at the hospital, and we don't want those to fall off the agenda too. So sepsis is a critical issue. Sepsis is something hospitals care directly about preventing, and certainly preventing people from going into septic shock and passing away. But just know that there are a lot of other draws on the leadership team as well. Next slide, please. So in short, I promised you maybe some happier news to end with, which is today we just put out a report, a new analysis that shows hospitals are improving their performance on key patient safety metrics and their performance is now surpassing the pre-pandemic levels. We all know that during the pandemic, there were enormous disruptions and they caused some retrograde movement in performance on some of the most important critical quality metrics, including some of the infection measures like CAUTI and CLABSI. No one wanted that to happen. Everyone wanted it to improve. We went into this report, this data analysis, which was done by Vizient with data from a national sample of hospitals that report their data through Vizient into CMS and CDC. They did this analysis on hospitals that have 19 months worth of data from the end of 2019 through the beginning of this year. And so we have more recent data than are available on Hospital Compare or elsewhere. And that data shows what we hoped, which was that hospitals are back at the pre-pandemic level. But to our surprise, it's even better news than that. Hospitals have managed to not only get back to pre-pandemic levels, they're better than they were pre-pandemic. And that is heartening news. I don't say that to you to suggest that the work is over. This is a celebration of accomplishment at this point, but we know the hard work continues. We know it must continue, and we are committed to working with our member hospitals to advance the health of the patients in our hospitals. And with that, I'll turn it back to Martin.
Thank you, Nancy. Very much appreciate your comments here. Again, we'll come back with questions after we get through the rest of the panel. I believe that the next three participants, if I saw correctly, are in the same room together. So we'll have them on the screen as the group. But I'd like to introduce Dr. Mark Sands, who is the Associate Chief Medical Officer of Northwell Health. Dr. Jessica Cohen, who is Assistant Professor at the Donald and Barbara Zucker School of Medicine, Hofstra Northwell. And Dr. Isabel Cohen, who is Principal Process Improvement in the Department of Clinical Transformation and Improvement. All three former colleagues, so hello to all of you. I very much look forward to hearing from you today. Thank you.
To you, Marty, to Kieran, and to Orla, thank you for the opportunity to allow us to present work, which, Marty, you know very well. I've inherited a lot of the work that you were lead champion on, and this is the opportunity for us to discuss the Northwell journey and where we are today, in very many ways echoing what Nancy Foster just shared with us, the opportunity for improvement now that the COVID pandemic has wound down. I'm going to start with our colleague, Jessica Cohen, who's a hospitalist at North Shore University and our Director of Evidence-Based Clinical Practice.
So by the end of our time together, we hope that it will be clear why we actually have three speakers today that are representing the critical pillars of physician, nursing, and quality leadership and the reinvigoration of sepsis care at Northwell. So I'm going to start by giving an overview of the Northwell sepsis journey, and then I'll pass it to Dr. Friedman, who will review the CDC's, their core element plan and what our own gap analysis showed, and then finally Dr. Mark Sands will discuss the Northwell action plan. So from the beginning, our primary goal has always been to eliminate all preventable harm related to sepsis. We've approached this goal by using the IHI collaborative model that accelerates improvement in healthcare through small iterative tests of change through the PDSA cycles, and that's how we drive sustained change. And we all know that sepsis outcomes improve when data is transparent and when lessons learned are shared system-wide. So this really gives a visual representation of this journey, and I think we're all very proud to say that Northwell began this journey back in 2008. That was long before it had really achieved, the national and international attention and recognition that it deserved. And it was under the leadership of our president and CEO, Michael Dowling, and our president of the Feinstein Institutes for Research, Dr. Kevin Tracy. It was the two of them coming together and realizing that we needed to focus on how to bring down our severe sepsis, our septic shock mortality across the system. And that journey began with just tracking and measuring the data for processes and outcome measures. In 2011, obviously, Dr. Marty Dorfler had joined us, and Dr. John D'Angelo, one of our ED chairs, partnered with the IHI, and that's when they started to implement the framework, the IHI framework, and they brought expertise in process improvement, and that's where there was a lot more focus on what we now know as, the bundle components of early recognition, antibiotic administration, blood cultures before antibiotics, getting the fluids in, and all of that focus was really on the emergency department at that time, because they realized initially the thought had been to look at ICUs, but it was too late in the process, and we'd already missed a critical step. With that, in 2012, through the support of a HRSA grant, we launched the Taming Sepsis Education Plan, and that was a focus on training clinicians to identify and treat sepsis rapidly through patient simulation. Efforts continued to pick up, and there was a lot more focus on this in 2013 after the implementation of Rory's regulations. By the time 2019 had come in, we'd already implemented an enterprise-wide order set, and that order set really allowed for everybody to speak from the same script, and it was really focused on getting all the bundle components in an easy way so that people didn't have to, it took mistakes out of the process, and if people used the order set, they would get better care to their patients in a timely fashion. So now we're at the, right before the pandemic, we got into really approaching almost getting under 20% mortality for severe sepsis and septic shock. This is a chart of raw mortality. It's not risk adjusted. And then after the pandemic, it took us a little bit of time to get back to all those core principles. And then last August, the CDC came out with the core bundle elements, and that really got our leadership to say it's time for us to rethink how we're going to approach sepsis across our health system. And you can see that, we've made a lot of progress over time. We've dropped almost 50% in our mortality for the severe sepsis and septic shock patients. But just as Nancy Foster was saying, the journey's not over. There's a lot more work to do. How big of a problem is sepsis? Well, it is the leading contributing DRG to mortality across all of our adult hospitals. And then this one, we were also set up here by Dr. Klein, who was showing those charts on pediatrics and how bundle compliance had an association with decreased mortality. And again, these are charts of abstracted chart data for the rolling year of April to March. And so it's not raw mortality, it's just the abstracted from our sepsis abstractors. And there's clearly a trend that when you use the order set, you have a lower mortality than when you don't use the order set. Not surprisingly with that, when you follow the bundles, so when you're compliant with your 3-hour bundle metrics, you're also having a lower mortality rate. And same thing with the 6 hours. Implementing sepsis care, it's challenging. I like to say that it's not the same as an MI or as a stroke where when your troponin is elevated or you have that lighting up on the head CT. It can be elusive, it can be tricky. it doesn't always have a clear time zero, and you always have to have your radar up and think, prove it's not sepsis. And that's where there really needs to be a multidisciplinary approach to the detection and management of it.
So I'll take over now from Jesse. So as we all have heard, and we all know that in August of 2023, the CDC released its sepsis program core elements, which is predicated on a structure of 7 points: hospital leadership commitment, accountability structure, the use of multi-professional expertise, taking action by implementing structures and processes to improve sepsis outcomes using evidence-based medicine, tracking by using measurement and trending our progress towards the goal of improving outcomes by early identification and monitoring that data, which allows us to achieve greater quality impact. Also, the reporting of sepsis information to our relevant partners. And finally, the education of providers, patients, and caregivers. If this looks and sounds familiar, it's because the core elements are were created on the basis of the antibiotic stewardship program that we are all very familiar with. These 7 elements will help us to achieve the goals set by the CDC. So, in response to this, we decided to move forward towards the reinvigoration of sepsis. In response to the CDC elements and inspired by this opportunity to improve, the sepsis faculty, who is a team of multi-professional sepsis subject matter experts that was created back in 2011 under Dr. Dorfler as the sepsis expert body of the Sepsis Collaborative and Task Force, which still meets monthly. That faculty requested that all hospital sites complete a gap analysis of the CDC core elements based on 15 of the 52 assessment questions that are posed at the end of the document. We had our improvement sciences teams aggregate all the results and divide them or separate them by tertiary and community hospitals for further analysis by the sepsis team. This information is assisting Northwell Health in reconfiguring its approach to sepsis care to include organized system leadership support and assistance from relevant service lines to targeted venues of care within the hospital. I will share with you a few examples of the results that we sorted by tertiary and community hospitals. The preliminary analysis of this information indicated that the tertiary hospitals appear less likely to have dedicated physician and nursing leads and physician nursing champions to ensure sepsis engagement. You can see by the data that the tertiaries have 80% compliance, while the communities have 80% compliance, while our tertiaries have 60% compliance. And similarly, having unit level physician and nurses, our communities have 30% compliant and the tertiaries are only 20% compliant. We tried to analyze why this might happen. So we thought that while the community hospitals have greater ability to operationalize and support a sepsis lead and champion program, the priorities, which are myriad competing priorities that our tertiaries have, probably is one of the many things that they have on their plate in order to get this done. It is still not 100%. And to have a successful sepsis infrastructure, we will require 100% participation. A similar trend in difference between tertiary and community hospitals can be seen regarding dedicated time to manage the hospital sepsis program. Many of our speakers today have mentioned or alluded to the fact that doing sepsis well does take time. Community hospitals appear to be able to give their teams more dedicated sepsis time, once again, because we believe that this is based on the myriad competing priorities that our tertiaries have. Regarding information on recognition of sepsis being displayed in prominent areas for patient-facing staff, the tertiaries do appear to be doing a better job there. Our goal, however, still is to achieve 100%. The gap analysis was necessary to guide us in our redesigning system. Therefore, to describe our plans, I will now turn it over to Dr. Mark Sands to discuss the newly developed and developing sepsis reevaluation process.
The arrival of the CDC core elements for sepsis were fortuitous. We had gotten back to our pre-COVID baseline for severe sepsis and septic shock mortality and realized that we needed to work in a different way. In many of the ways specified within the CDC core element program. Senior leadership met at the end of last year, shortly after the core elements were shared. And the first activity was a medical director retreat to establish the accountability at each of the major hospitals in the health system. Missing from this slide are the two psychiatry hospitals and a specialty surgery hospital, which will be included at a later time. It became very obvious to us looking at the questions, the risk, the gap analysis questions in the core element plan, that the intersection of the hospitals with the service lines in different venues of care, the emergency room, the med-surg floors, the ICU, the pediatric units if the hospitals have them, the obstetrics units if the hospitals have them, and the pharmacy departments in those hospitals, that those intersecting nodes were going to be different between each of the hospitals and required attention from the service lines. In many cases, the service lines don't have the improvement science or the performance improvement personnel to drive that. The other missing element that has been alluded to and described in this conference before is the equity of care issues between the diverse communities we serve, both socioeconomically, linguistically, racially, and so a direct entry to each of the hospitals from our equity leadership was involved in that matrix as well. Given the fact that there are these multiple intersecting points that need to be perfected in each hospital, next slide, we arranged for the service lines to meet with the hospitals and to discuss their individual venues of care and create key driver diagrams, particularly secondary drivers that are unique to their hospital settings. In this example, we're showing the IPSO key driver diagram that the Cohen's Pediatric Hospital has used. But this allows the service lines to look at the opportunities, not just at Cohen's, but where pediatric patients are also seen outside of the pediatric hospital. And next slide. To facilitate that work is the work of the group that I co-lead, the Clinical Transformation and Improvement Department. This department consists of 28 people, 7 improvement science experts, system engineers, project managements, and clinical experts like Dr. Friedman and Dr. Cohen. The particular task for these groups that are meeting now are to look at the venues of care within the individual hospitals, again, with the service lines, understanding where the differences are between the ICUs and the various hospitals in the health system, working into that, the development of specific secondary drivers that need to be obtained to make sure that every one of the key drivers and goals of the hospital sepsis program are attained. This work is starting now. It is underway and will culminate in a system-wide leadership retreat at the very end of October. We really feel that we've exhausted the guiding principles that we've started with, the attention to order sets, the attention to education. Now it's the time of accountability and specific site work to look at where we can move things forward. Thank you.
So, Nancy, I want to start with you if I could, and I recognize that you're not running a hospital, but you raised in your presentation the sort of struggles of hospitals and staffing and finances and all the rest. We heard earlier how much money it is costing hospitals to have to care for sepsis patients, and I'll reference work that I did when I was at Northwell, where we actually showed that there was a a margin improvement of full compliance with the sepsis bundle, where the hospital margin generated on the population who got full compliance was actually greater than patients who did not, with the complexities of all those finances, and raise within the staffing burdens that are going on right now, the moral pain that is experienced not just by the families such as the Claytons and the Stauntons when their loved ones experience poorly treated sepsis, but the staff who were involved in it. I'm sure that in all of those circumstances, the nurses, the doctors, et cetera, struggled with the failure of themselves and others around them to be able to correct for the inadequacies that have been encountered prior to or during, their part of it. So, as the sort of representative of the hospital world, I struggle with the justification for this not being job one, I guess, is to put forward in this setting that we're in right now.
And by this, when you say this is job one, you mean
fixing the crisis in sepsis care, which is the largest which contributes to mortality and the largest fraction of patients that we encounter in the hospital, and contributes to enormous cost and contributes to enormous pain and loss in our society.
It does. It's a critically important issue. What I would tell you is that each hospital looks at their own data and identifies different things that they think are both addressable by current knowledge and frequent in their own organizations. And that, I am not in those rooms. So I do know that we are frequently asked and to provide additional content around maternal mortality, infant mortality, door to balloon times for people coming in cardiac arrest, and a variety of other things that also take lives too early. And so I think that part of the issue here is helping people understand the true impact of sepsis in their own organization, and the ability to see it. Your colleagues from Northwell, you and your experience at Northwell had to bring it out of the dark and highlight it in order to really marshal the kind of work that you were doing, if I'm understanding correctly.
Yeah, that's certainly true.
Yeah.
To my Northwell colleagues, you've mentioned a number of pieces of this, and Dr. Sands, at one of your last slides, had the verticals of the hospitals and the horizontals of the service lines. And you talked about the value of the order sets, clearly demonstrating when they're followed, you get improvement. And you mentioned during my tenure there, Dr. D'Angelo was a leader in the emergency department. I was at the time a leader in critical care. Jessica is a leader in hospital medicine. As direct involved, we're able to mobilize our communities somewhat. How are you mobilizing the OBGYN community? How are you mobilizing the surgical community where you don't have those folks? And I'm willing to bet if you did a dissection of your order set compliance, you would find service line specific deficiencies. How do you start getting farther into this and addressing it now?
So, Marty, directly with the service,
Are we on? Yeah. You can hear us.
Directly with the service line leadership. So this is at the senior most level of the organization, the chief medical officer for the health system, chief quality officer for the health system, the deputy chief quality officer for the health system, the two nursing directors, the chief nursing officer and her deputy. This has been through the PICG group, our performance improvement quality group. This has been elevated to the top overall quality priority for the organization. So non-compliance is not okay. And we are meeting with the leaders directly. The chairs, their designated representatives, when they're not available, with their administrative leads, to have them understand what the request is and how we in clinical transformation with our improvement scientists are going to work with them in each of the venues they serve. So that saying we have complicated patients in our ICUs and sepsis is just another problem for them is not okay. So we're going to look at the best practices of the ICUs in the health system. Part of the accomplishment of the IHI Collaborative is that we were able to share some of those. They didn't always take root because they didn't come from the top leadership. And so at this point in time, the October 29th retreat is going to be the open season on that sort of thinking across the health system.
The last question, and this comes with me being highly knowledgeable in the weeds of your organization. And so if it was somebody else, I probably couldn't ask this, but there was a time where the performance-based compensation component of senior executives had an element of sepsis bundles included. Are you there at this time? Or are you contemplating going there? It was motivating at the time.
So it's there in the emergency department. There as the venue within the system that sees most of the patients. It has not yet been adopted through OBGYN or through the like, but I can easily see that happening as well.
Thank you. Let me just check and see if I've got questions from any of the other.
I wanted to add too to your point about the order sets and not necessarily knowing that the other service lines are going to be using them as well. I think another thing to realize in the Northwell trajectory is that we're transitioning to Epic, and it is going to allow for a big opportunity to leverage that true change that's happening enterprise-wide. And part of it has been a very thoughtful process of our sepsis faculty inputting into what that sepsis build looks like in Epic and how it's going to be viewed from different eyes and different venues across the system to make sure it makes sense for an OB to still use that order set and that it's easy enough for them to follow so that they're treating their patients with the rapid treatment that they deserve.
And in addition, Marty, as you well know, we have had meetings over the last month with every single service lines, leadership, nursing leadership, clinical leadership, and quality leadership, to tell them what the expectations are and that they have to take those expectations, and we're sending them the information to share with the different hospitals that have that particular service line. And then we're going to have meetings with them again, and we're going to do with our improvement scientists, we're going to do their key driver diagrams with them after we get their input. And then we're going to be meeting with them at their quarterly meetings. They are expected to meet monthly and get together as a service line quarterly, and we will be on those meetings in order to help them with their process improvement, their PDSAs, and any other improvement science they might need to do.
So just as Nancy mentioned in her slide deck, she had 2 bullet points. One is to bring in the improvement team. The improvement team is hardwired into this in every venue in the health system, through those service lines at the intersecting nodes with the hospitals. The hospital leadership teams are now CNOs, CMOs, and chief quality officers in each hospital. And so the responsibility piece, the accountability piece here is now firmly established. And that, I think, is the major development since you left, with the help and encouragement of the CDC core elements, which specify that.
Right.
And I think with that in hand, it becomes an easier lift to senior leadership and an easier position for senior leadership to echo through their chairs and service line chiefs.
Mark, your comments are actually, I think, a great closing statement to a high degree, in that what you've said, a couple of key pieces, just to reiterate: hardwired, and and referencing back to our earlier conversations, with the assistance of the new CDC core elements, and you have a team that's been in place for a while, so you're able to jump on it more quickly. Hopefully, Nancy, and as you talk to others and others who are paying attention to this, folks will be able to take those CDC core elements, take the new data coming out of AHRQ and pay attention to it as the CDC outcome measures turn into CMS measures to be have organizations held accountable. The type of work that, and talk a lot about Northwell because of my history with them and involvement with end sepsis and such all the time. There are a lot of organizations out there that are doing good work. There are a lot of organizations out there where it's not as much of a priority, and that's again coming back to my question to you, Nancy. And again, I'm not looking for you to answer it again. The CEO doesn't have to do this work. They simply need to tell everybody it's important, and I expect it to be done. And I think that evolution of all of these weights on there will drive us there. I see Kieran on my camera. I don't know if you want to have closing comments here or not, but if you would like, I'd happy to turn it to you.
If I could ask everyone just stay tight for just 2 minutes. We have a few announcements and some house cleaning, as we might say. But first and foremost, there's a young lady called Sabine Horner who has put this together. Everyone has heard from her 40 times a day. She's worked on the Hill. She's put this together. She's a million more jobs going at the one time. So there's a big thank you very much, Sabine. We all know who you are. To the sepsis families who are on today, Stephanie Hobson, Clayton Anderson and Orla Staunton. What can we say but big hugs to everyone? Our sponsors are Northwell, Cytovale and Inflammatics, and we have some other. I just want to do a thank you to you, Dr. Dorfler. You've been there for day one, and with us, there's no getting out. We have your cell number, so you're with us. Thank you very much. Dr. Cohen, Dr. Owens, Dr. Michael Bell, Dr. Klein. Last but not least on that panel is Dr. Foster Gueston. Foster Gueston is above and beyond. He's always there for us, and he was in Washington, and we ran the feet of him for 3 days. And he's also on the expert panel. Nancy Foster, thank you very much for coming on. We look forward to meeting you in persons, and we look forward to working closer with your organisation. And I know there has been a lot of interaction with your organisation and Senator Schumer's office in the run-up to what we're going to talk about later on. Thank you very much. Northwell doctors, Dr. Sands, Dr. Cohen and Dr. Friedman, thank you again. But Northwell is a gold standard in sepsis. And when people kind of hand-wring and they wonder what they can do, we say, well, if Northwell can do it, call Michael Dowling. And he'd put you on to the people, if you're wondering. They are very good. When Rory died, we started off, the first bit of brochure we went to Capitol Hill with was this graph, because we were handing out a piece of paper and no one was reading them. And at that time, sepsis was killing 258,000 Americans a year, and it was costing about 20 billion. It's now tripled, and it's 350. What we did with the help of Dr. Shah, Commissioner Shah, Dr. Foster Gueston, and Northwell and yourself is that we drew up what's called Rory's regulations. And after much tough pushing, we got them through New York State. And down along the line, as Orla and I traveled other states to try and get them through, because if they're saving lives in New York, they should be replicated. And I was just doing up the figures. Since then, a number of states have, as Dr. Owen said earlier, have replicated it. There's almost 50 million Americans in 6 states now covered by a form of, based on Rory's regulations. Illinois, New Jersey, Rhode Island, and just in the recent months, Maryland passed a bill replicated on Rory's regulations. So to people looking on to this and saying, can we move this next initiative? Well, look where we've come from with 50 million. And I think what we're looking for, and I'm just going to spend a minute on the new bipartisan legislation, because with all the groups, Senator Schumer's office and ourselves brought all interested parties into various rooms and said, here's a broad base. We want you to come to it. We want something, because Senator Schumer's office said, there's no point us introducing something that people are going to lobby against. And this week we brought a number of families, as you saw from the clip, and I want to just say a thank you to those on the hill. Was Bud, Clayton, Stephanie, Foster, Chris, Orla, Susan, Colin, Patrick, and a big thank you to Donna, who came with us in our Heart Squad today. And you know what? Going into the legislation, the House divided cannot stand, and legislation that there's anyone going to be in any way opposed isn't going to get passed. And we have to row in the same direction. And I think that's what we're doing is now, because in the past, we have met senators, hospital groups, patient advocates. We have not met anyone who says, I don't think this legislation should pass. No one has said that. Now, what we do need, though, is we need people to get behind the bill. In the next few weeks, we're going to do a briefing here similar today on what the bill is. We have always made a step into the House side of it because we know after the Senate, which we're confident we'll get through, the House is a bit different out there. So we have met and had relationships with the Appropriations Committee in the House, Ways and Means Committee, Energy and Commerce. But we will need everyone out there. What we did yesterday to bring some families means we'll have to bring a lot more when it comes to the House, because we need to get this passed. We need to get the president's desk, because I think everyone on here will see how successful the Parkinson's lobby recently worked. They got the legislation through with more than 95% in both houses. President Biden signed it in July. So we have something that we need to do. We need to get this legislation done because we owe it to Emily, to Rory, to Crystal, to David, to Susan, the 350,000 families that will buy a coffin between this and we miss it again, and the 3.5 million people that have died since Rory and others died. I'm appealing to everyone who's watching this to take an interest in it, because we need to get behind the legislation. We know we'll have legislation. Sooner saves lives rather than later. The bill number is S5206. If S5206 will make history because it'll save millions of Americans. And with that, I want to thank everyone a million. God bless you all. And please, let's get working to get this bill passed and stop this killer in our midst. God bless you all.